seizure disorders. This is also a big topic, and in this topic I'm going to talk about the definition of seizure disorder, followed by classification, what is the pathophysiology of seizure, okay. Then we talk about how to investigate and treat a case of seizure disorder. What do we mean by epilepsy? What are the different types of epilepsy, and what is the management? Followed by what is status epilepticus and how to handle it. So this is a relatively a big topic, but very important from the neurology aspect. Let's start. Now, seizure is a paroxysmal event which may be motor, sensory, behavioral, or autonomic. So it's a paroxysmal event which may be motor, sensory, behavioral, or autonomic, and it occurs due to abnormal, excessive, hypersynchronous discharges from the central nervous system neuron. You can define seizure on your own way, but the important points has to be there. So seizure is a paroxysmal event which occurs because of hypersynchronous excessive discharge from the central nervous system neuron, and that seizure can be motor seizure, sensory seizure, behavioral, also known as psychic seizure, or autonomic seizure. Now, seizures are roughly divided into minor and major. Now, major seizure, they cause loss of consciousness with the patient falling to the ground and presenting with a history of blackout. Major seizure like grand mal seizure, for example, it usually is associated with loss of consciousness, and the patient falls on the ground, okay, after that, and there is a certain period of coma or loss of consciousness. Whereas the minor seizure causing alteration of consciousness without the patient falling to the ground. So this is a slight differences between major and minor seizure. About 5 to 10% of the general population have at least one seizure episode during their lifetime. So this is a very common disorder in general population. And when you start your practice in a hospital or clinic, a lot of seizure cases will come to you, especially if you work in the emergency room of any hospital or in the neurology clinic or the ward. Now, with this introductory slide, let's talk about what are the causes of seizure in different age group, according to the age group, okay? See here, in neonate, these are the common causes of seizure. Perinatal hypoxia means birth asphyxia. At the time of delivery, if the newborn suffers from hypoxic damage to the brain, that is called perinatal hypoxia. Seizures are very common. Central nervous system infection like meningitis, meningoencephalitis, encephalitis, brain abscess, okay, these are the different examples. Metabolic disturbances like hypoglycemia, hypocalcemia, hypomagnesemia, all of them can lead to seizure disorder. Regarding infants and children, febrile seizure is one of the commonest cause of seizure at that time. Okay, from 6 months to 6 years, febrile seizure is seen. Febrile seizure means first fever comes because of some infection, then that seizure fever will lead to seizure. It is febrile seizure. We need to rule out central nervous system infection in febrile seizure. CNS infection also causes seizure during that age, and trauma is a common cause. Now, adolescent and adult, okay, the common causes of seizure would be infection like meningitis, encephalitis, brain tumor, illicit drug use, okay, illicit drug use like cocaine, amphetamine, alcohol withdrawal, and okay, some cerebral tumor which we already discussed. Regarding the older individual, cerebrovascular disease, which we just discussed in the morning class, a stroke, brain tumor again, metabolic diseases like uremia, hepatic failure, okay, this is known as uremic encephalopathy, this is hepatic encephalopathy, electrolyte abnormality, sodium imbalance is the main one, and hypoglycemia, along with degenerative diseases of the brain. Okay. these are the neurons are dying away. So these all are different causes of seizure disorder. A very common question we like to ask in the exam. Let's move on. Now let's classify the seizures. Now, see here, just pay attention. The seizure are classified into different headings. They are generalized seizure, partial seizure, and unclassified seizure. So generalized, partial, and unclassified. Now, regarding the primary generalized seizure, these are the types: absent seizure, tonic-clonic seizure, tonic seizure, atonic seizure, and myoclonic seizure. Now, tonic-clonic. Tonic means the spasm of the muscle, and clonic means the rhythmic relaxation and contraction, or flexion and extension. That would be a better term. Rhythmic flexion and extension of the muscle group. That is tonic and clonic movement. Myoclonic is a jerky movement of some of the muscle group. So these are primary generalized seizure. Now, why the term primary generalized seizure is used, there is a reason. There is one variety of partial seizure which is secondary generalized. Means it starts from partial seizure, then it involves the whole body. So this is partial seizure with secondary generalization. Okay. Just to differentiate these generalized seizure from that condition, the term primary generalized seizure is given. Now let's go to the partial seizure. Partial seizure means some part of the body affected, not the whole body, like simple partial seizure, complex partial seizure, and partial seizure with secondary generalization. Three important types. Among the simple partial seizure, it can be motor seizure, it can be sensory seizure, it can be autonomic, and it can be psychic. But motors are much more common than other. Complex partial, the difference from simple partial here is the patient has a loss of consciousness for a brief period of time. That's why it is called complex partial. Unclassified seizure, they are neonatal seizure, they are infantile spasm, also known as hips arrhythmia, and they are febrile seizure. Neonatal seizure, hips arrhythmia, and febrile seizure. So these are some of the types of seizure. Okay, very important question in the exam. Now, the next part of the discussion would be, what is the pathophysiology of seizure disorder? What is the mechanism of seizure disorder inside the brain? Let's talk about the pathophysiology of partial seizure first. Now, pay attention here. See this. Okay, here is the focus. This is a focus of seizure. Okay, here is a lesion. You remember like that, and it is causing some electrical discharge. This electrical discharge is dispersing in the nearby area. Okay, that is diencephalon, and then then it may go to some other places of the brain. See there. So a partial seizure originates from a paroxysmal discharge in a focal area of the cerebral cortex. This is the focal area. This is the temporal lobe of the brain. So focal area. The seizure may subsequently spread to the rest of the brain. Secondary generalization via diencephalic activating pathway. This is diencephalon. Thalamus is a part of diencephalon. So it will go to thalamus, and from there it may go to other parts of the brain. Just now I told you. If it doesn't go there, it will only lead to a partial seizure, like a simple partial or complex partial. But if it goes to the diencephalon, then it converts into secondarily generalized seizure. That is the mechanism. Now, what about primary generalized seizure? Now, the focus itself is in the diencephalon area. If the focus is here, then it can easily transmit to most of the part of the brain. result in generalized seizure. A perfect example is generalized tonic-clonic seizure. These are some of the important points. Now let's talk about this individual type, the important points. We cannot talk in detail regarding everything, but what are the important points we'll definitely highlight. Regarding the simple partial seizure, okay, in a motor type of simple partial seizure, there is clonic. Clonic movement means repetitive flexion and extension type of the movement at the rate of 2 to 3 Hz. So this is a hallmark of simple partial seizure, clonic type of movement. Other features are Jacksonian march and Todd's paralysis. Jacksonian march and Todd's paralysis. Jacksonian march, probably from that group it may go to the some other group also, okay, one after other. And Todd's paralysis is after that episodes of seizure, the involved muscle group may be paralyzed for certain duration, and after that duration the muscle will recover the strength. This is called Todd's paralysis. It is one of the important differential diagnosis of TIA. We have discussed this before. TIA, transient ischemic attack, can also present in the same way. Todd's paralysis also presents in the same way, but a big difference is Todd's paralysis occur after that episode of seizure, whereas TIA usually doesn't. Now, sensory partial seizure presents with tingling or electric sensation in the contralateral face and limb. Tingling or electric-like sensation in the contralateral face and limb. This may be the manifestation of simple partial seizure. Many of the time we cannot even diagnose it. If there is a repetitive sensation like this, then we can suspect this and then confirm it. Versive seizure means forced deviation of the eye to the opposite side due to frontal epileptic focus. There is a frontal eye field in the frontal lobe of the brain. In that area, if epileptic focus is there, then there is a forced deviation of the eye to the opposite side. This is called versive seizure. And visual seizure, when there is the occipital epileptic focus present. And this mainly present as a visual hallucination. Visual hallucination. Now, what is hallucination? Okay, wait, maybe I have, okay. What is hallucination, guys?
Sir, if
When something is not there, but we can see
that it is there.
the patient say there is something
False
Okay,
image, negative, false
Actually
image.
not exist.
good, good,
It have 5 types: visual,
false belief.
visual
good,
touch, and
nice.
False belief.
So very good answer. Okay, I'm getting from you guys. Very good. Keep it up. So visual hallucination is a type of hallucination. Hallucination is the disorder of perception. Disorder of perception. For example, visual means there is no object there. Okay, there is no object there, but the person is seeing that object. This is called visual hallucination. Nothing is there, but the person is interpreting there is something, definite object. And this is one of the very important feature of psychiatric disorder. Okay, but sometimes even in temporal lobe epilepsy, okay, or other types of epilepsy or seizure disorder, different type of hallucinations can be seen. Auditory hallucination may be there, tactile hallucination may be there, gustatory hallucination may be there, and visual hallucinations may be there. So these are the important points. Now, what about a psychomotor seizure? Psychomotor seizure, let's talk about it. In this condition, the seizure manifests as alteration of mood, memory, and perception, and these are mainly derived from seizure of temporal lobe. So these are also a part of temporal lobe epilepsy. This is important diagnostic point: temporal lobe seizure or temporal lobe epilepsy. So they manifest as alteration of mood, memory, and perception. Now look at some of the clinical feature in psychomotor or temporal lobe epilepsy. Undue familiarity, which is known as déjà vu. Okay, déjà vu. It means undue familiarity. This is a French term or French word, déjà vu. Now, what does that mean? The person feels, the person has that type of perception, okay, that the thing which the person has never seen before, okay, or the place which the person has never visited before, that thing or that place looks very familiar. They have never been to that place before, never. But whenever they go to that place, they think, I have been to this place many times. Everything looks quite familiar here. Okay, so this is the disorder of perception. This is called undue familiarity, déjà vu. This is called déjà vu. Sometimes something which you feel, it's quite familiar to us. Okay, so déjà vu. Opposite to that is jamais vu. Okay, jamais vu is a unreality. This is also a French word or French term. Unreality means the thing which you have done many times before, the thing which you are really, you really know that thing, how to do everything regarding that, or everything regarding that place or whatever. Now when at this moment you think that you have never been to that place, okay, you think that this thing is totally new to me, it is a naive thing, okay, very new, I know nothing about it. That type of feeling is called unreality or jamais vu. So these are important a term in psychiatric illness. Sometimes the patient will have complex hallucination of sound, smell, taste, and vision. Sometimes the person suffers from emotional change, and sometimes there would be some visceral change like epigastric pain, discomfort, or even nausea. So this psychomotor seizure or temporal lobe seizure or epilepsy, is an important condition in the clinical practice. Now, let's talk about complex partial seizure. Okay, a bit similar to simple partial seizure, but only one important difference here is patient lose consciousness level for certain duration. Remember that single important difference. So these complex partial seizure, they may be associated with aura. Okay, now this aura may last for seconds to minute. Now aura means, okay, this aura means the person knows the seizure is going to come. The person has that feeling, that some clues have been given by the body that seizure will be coming within seconds or a minute, and seizure will be there. These are called aura. Sometimes a flashes of light would be there. Sometimes some ringing sensation occurs inside the ear. Sometimes abdominal discomfort occur. Sometimes some tingling and numbness type of sensation occur. So the person knows this is aura, so that seizure is going to come. This is a common thing in complex partial seizure. There is loss of awareness or loss of consciousness, we say, lasting for several minutes. Okay, and these are the different things which also occur here, like alteration of the mood, memory and perception, such as déjà vu or jamais vu. There may be hallucination. Okay, there may be emotional change, or there may be visceral sensation, exactly like a temporal lobe seizure which we just discussed. Patient may stare and be unresponsive to question. This is known as loss of awareness. Patient may constantly stare at one point, and during that time that person is unresponsive. Even if you call that person by name, or if you produce a loud sound, the person may not respond. Some of the patient may develop a feature of automatism. That means smacking of the lip swallowing, picking at their cloth, that type of movement. So it doesn't look good, isn't it? It doesn't look normal. This is called automatism. This may be a part of complex partial seizure. Now, one important point I like to correlate quickly here, even in typhoid fever, we have studied this before. In typhoid fever, because of the high grade fever, sometimes the patient may pick at their cloth. Okay, this is because of delirium, which is caused by typhoid fever. Delirium is very common there. Okay, so this type of correlation has to be done whenever it is possible. Complex partial seizure arising from the anterior parts of the frontal lobe, okay, which may produce bizarre behavior patterns sometimes. And these bizarre behavior patterns, some of the examples are ill-directed motor activity and incoherent screaming. Now, ill-directed motor activity means suddenly you go to a person and slap the person without any reason. That is ill-directed motor activity. Another one is screaming unnecessarily. There's no need to do that at all. You cannot give any explanation for that. So these are bizarre behavior, which may be a manifestation of complex partial seizure. Now, after this, let's talk about grand mal seizure, which is known as generalized tonic-clonic seizure. Probably clinically, once we come across this type of seizure, we'll never forget it. Never. Once you see this type of patient who is seizing in front of you, generalized tonic-clonic seizure, that picture will set in your mind, okay, for the rest of your life. And you don't want to see that type of patient again. It doesn't look good at all. Okay, this is grand mal seizure. Now, it may be preceded by partial seizure or aura. This partial seizure is called generalized, okay, a seizure which is a secondarily generalized one, not the primary. That's what we talked before. One type of partial seizure, or the seizure which is localized to one half of the body or one part of the body, it may start from one limb, for example, or the hand. And from there, it may spread towards the whole body. So, grand mal seizure may be a primary one, or sometimes the generalized tonic-clonic seizure may be a secondary generalized. In this condition, there is tonic contraction of the muscle. The tonic contraction of the muscle. Now see here, this is important one. And after that, patient goes rigid, and patient becomes unconscious. Patient cannot maintain the posture, so they fall down heavily if standing, and often sustaining injury because of that heavy fall. And sometimes if there are some sharp weapons or instrument around them, they can have serious injury. Sometimes they may fall from that particular area where they're standing. For example, if they are standing very near to the stairs, they can fall from the stair. If they are standing in a very high place, they may fall from there, and they even die from that type of injury, or sustain head injury or multiple fracture. This is a very, very important point. That's why whenever we diagnose a patient with generalized tonic-clonic seizure, we always counsel like this: never go outside alone. You have to be accompanied by someone else, maybe a family member, maybe a friend, okay, maybe a girlfriend, boyfriend, whoever. Okay, someone has to be there all the time with the patient. If the patient has that type of aura of feeling seizure is going to come, patient immediately, okay, should go to a safe place. So these are very, very important point. Now, after 10 to 20 seconds, the clonic phase start. So what happens here? In the beginning, there is tonic phase. Tonic phase means rigidity. The muscle vigorously contract. After 10 to 20 seconds, the clonic phase start. Means patient start to shake the muscles now. This is rhythmic flexion and extension type of movement. So this is typical tonic-clonic seizure. This period doesn't last for more than 1 minute, but if it lasts for more than 5 minutes, practically you call it status epilepticus. But theoretical definition of status epilepticus is something different. According to that theoretical definition, status epilepticus should occur for more than 30 minutes, either continuous seizure, or if there are episodic seizure but there is no regain in consciousness level in between those episodes, then also we call it status epilepticus. That is a theoretical one, okay? But practically, if a person is having continuous seizure for more than 5 minutes, we consider this as a status epilepticus and treat accordingly. Now, generalized tonic-clonic seizure or grand mal seizure has an important post-ictal phase. The patient becomes unresponsive. There is muscular flaccidity. There is hypersalivation, and there is incontinence of the urine and stool. Incontinence of the urine and stool. Now, see there? Let me explain this. So, post-ictal phase, the patient may be unresponsive. Here, okay, means the person is in coma or the person is unconscious. There is flaccidity of the muscle now. In the beginning, there was contraction of the muscle. Now, in post-ictal phase, there is flaccidity. Salivation, there is drooling of the saliva from the mouth, and there is incontinence. Some of the patient may bite their tongue also. Tongue biting is quite common in grand mal seizure. Okay, tongue biting is quite common there. Sometimes the patient may pass stool and urine on the cloth. You see that is called incontinence. No control over stool and urine. Patient gradually regain consciousness over minutes to hours, and there may be headache, fatigue, and muscle ache after that. There is a vigorous contraction of the muscle, so whole body will have pain after the person becomes all right. There is headache and there is a sense of fatigability. These are important features of grand mal seizure. One important point I forgot to mention here, during the initial period of the seizure, the person is rolling the eye upward, okay, drooling the saliva, biting the tongue, and passing stool and urine. These are very, very important point of true seizure. There is a condition known as pseudo seizure or false seizure. These points are not commonly present there. Now, in EEG, if we do EEG, electroencephalogram, this is one of the investigation. Okay, the tonic phase has low voltage, fast activity, followed by high voltage polyspike discharge. Sometimes there may be spike and wave as well. This is done with the help of EEG. Okay, so EEG can be one of the important investigation in seizure disorder. Okay, now let's move on. After grand mal seizure, okay, grand mal seizure, let's talk about absent seizure, which is known as petit mal seizure or petit mal epilepsy. Now, this absent seizure is seen commonly in children. Now, what happens? Why it is called absent seizure? Now, listen carefully. The child suddenly stops the activity, whatever the child was doing, continuously stare at one area. During that time, there may be blinking and rolling of the eye, but that child failed to respond to the command. So it doesn't only occur in the child. Definitely, it is more common in children, but even adults are suffering from this. For example, if some person is standing, okay, and talking with you, if absent seizure occur in that person, the persons will stop that activity, continuously stare at you, or probably in some other object, and even if you call him by his name, okay, or shout at him, the person failed to respond. So this is absent seizure. The attacks are usually briefer and very much more frequent. It may happen up to 20 or 30 times a day. So this is, many episodes in a day. There is no post-ictal confusion in absent seizure, and one important point is the person do not lose posture. Means the person keep on standing. If the person was standing, the person do not fall on the ground, which is not seen at all in grand mal seizure. In grand mal, there is a heavy fall, okay, heavy fall. Person cannot maintain the posture, but in absence or petit mal seizure, the person can do that. This is an important point. Now, another variety of the seizure is atonic seizure. Atonic means loss of tone. See that the name itself suggests atonic, loss of tone. So because of the brief loss of muscle tone, the person will have heavy fall now with or without loss of the consciousness. So what is the difference between grand mal seizure and atonic seizure now? In grand mal, there is contraction of the muscle in the beginning. After a few seconds, it will be rhythmic flexion and extension, which is called clonic movement. Person will fall there also, but here there is decrease in muscle tone. There is no increased tone at all. This is a major difference. It occurs only in the context of epilepsy syndrome with other forms of seizure. So there are some epilepsy syndrome which are very difficult to diagnose. Person keep on having difficult seizure. So atonic seizure may be a part of that. Now, okay, before we finish this half of the class, let's talk about what are the trigger factors for seizure. Triggering factor means this person may be having seizure disorder before, maybe having 1 or 2 episodes of seizure before, or he or she is a diagnosed case of seizure disorder. What are those factors which will again cause seizure in that patient? These are called trigger factor. Sleep deprivation is one of them. If the person keep on watching movies till late night and he is a seizure disorder patient, that is not good at all. There should be enough sleep, otherwise seizure will keep on coming. Intake of alcohol, okay, and especially during the withdrawal of alcohol, seizure will happen. Recreational drug use or misuse, seizures are common to occur. Physical and mental exhaustion is also not good in case of seizure disorder. The person should not do that type of activity which will make them completely exhausted. Avoid the flickering light. Flickering light, like in discos, isn't it? In dance bar, those type of places, there is flickering light. So the person who is having seizure disorder or epilepsy should avoid those places. Okay, the person should not, sit in front of the television or computer screen for a long time. This is very important one. They need to work. I'm not saying they don't use those type of gadgets. Life is impossible without these gadgets these days, but it doesn't mean we stick ourselves 24 hours in front of those things. Intercurrent infection and metabolic disturbances are some other important trigger factor. Any infection in the body, any viral, bacterial or fungal or any other, can trigger seizure attack. And some metabolic disturbances like hyponatremia, hypoglycemia, hypoxia itself can easily cause seizure. It is said that they decrease the seizure threshold. That's why seizures are easy to occur. And some uncommon trigger factor like loud noises, music, reading, and even hot bath or sauna, those type of things may be a triggering factor for seizure. So these are the a triggering factor. Sometimes there may be some unknown. We don't know why seizure is recurring in this patient. So many of the time they are unidentified also. But as far as possible, if we identify them, we ask the patient to avoid them. Okay, so this is a very important counseling. Now, what is epilepsy? What is the definition? What do you mean by epilepsy? And what is the difference between a seizure and epilepsy? Now, these are the questions which will be asked to you. Now, see here. Epilepsy is occurrence of 2 or more unprovoked seizure. Now, see there. 2 or more unprovoked seizure is epilepsy. Unprovoked means there should not be any other causes which may lead to seizure easily, like infection, okay, like trauma, for example. So they should not be there. This is unprovoked seizure. 2 or more episode is epilepsy. So epilepsy means there is a tendency to have seizure. In epilepsy, seizure tend to recur and as a rule have no immediate underlying cause in majority of the patient. This is a very important point. They have no immediate underlying cause in majority of the patient. But in some other patient, the causes are there and they leads to repeated episodes of seizure. But usually they have no immediate underlying cause. Let me give you one example quickly. If a person comes with 3 episodes of seizure and we have done CT scan, the CT scan came normal, means I don't find any identifiable cause inside the brain. This is a perfect case of epilepsy. Now, let's proceed further. We are talking about epilepsy. So we define epilepsy just now. Epilepsy means occurrence of 2 or more episodes of unprovoked seizure. And usually after investigation also, epilepsy doesn't have any causes there, okay, in majority of the cases, but some of the cases we can find out certain causes. Now, the types of seizure are same what we discuss in seizure disorder, like simple partial seizure, complex partial seizure, absent seizure, tonic-clonic, tonic only, atonic, or myoclonic. The seizure types are same because epilepsy is a repeated, episodes of seizure itself, isn't it? So seizure type would be same. If we do EEG, it will show some abnormal changes or abnormal finding like focal spike or sharp wave or even generalized spike and wave. Now, epilepsy may arise from some of the anatomical site inside the brain. That site may be cortex, maybe temporal lobe, okay, maybe frontal lobe, or maybe parietal lobe, or maybe occipital lobe. These all are parts of the cerebral cortex. Apart from that, it may originate from diencephalon, which results in generalized type of seizure, or it may be multifocal here and there. So these are regarding the anatomical site of epilepsy. Now, already talked about, in majority of the cases, we don't know what is the cause, but in some pathological cause are identified, like genetic, developmental, or during the development of the brain. If some abnormality occurs, then also epilepsy can result. Tumor, trauma, vascular, infection, inflammation, metabolic, drugs, alcohol or toxin, and degenerative. Sometimes these causes can be identified by the investigation and they repeatedly leads to seizure even without some provoking causes. They are also known as epilepsy. Now let's move further. Let's classify this epileptic seizure, and this is the International Classification of Epileptic Seizure, ICES, and you don't see any difference here. and this classification you already gone through. Now see here, partial seizure, generalized seizure, okay, and some other varieties are also there, maybe unclassified like that. But these are the two main. So partial seizure at least can be localized to one hemisphere. These are the commonest type of epileptic seizure. They occur because of the focal lesion in one area of the brain, and the part of the body which is controlled by that area of the brain will develop seizure. Subtypes can be simple, complex, and secondary generalized. Already talked about, so let's not waste a bit of time here. Okay. Regarding the generalized, the site of onset cannot be resolved to one hemisphere. That's why it is generalized. It is well spread to the whole brain. That's why whole body would be shaking as a seizure. Or it depends, in case of absent seizure, there's no shaking, isn't it? But majority of the cases I'm talking about. Myoclonic seizure, clonic, tonic, tonic-clonic, and atonic. So these are the different types of generalized one. Now let's move further. What are the causes of partial seizure? Partial seizure is one of the type of seizure disorder. So let's talk about the causes. Idiopathic means we do not know the cause even after good investigation. Focal structural lesion inside the brain. Okay, focal means in some localized area of the brain, if there are some lesions, that can be a tumor, that can be a hematoma, okay, that can be a neurocystic sarcosis. Okay, so these are the different example. Genetic diseases like tuberous sclerosis, neurofibromatosis, and von Hippel-Lindau disease. These are the some other. Now, what do you mean by a tuberous sclerosis? I like to provide some of the important information. Tuberous sclerosis is autosomal dominant disorder which runs in the family. Now, that means there is 50% chance of recurrence in each pregnancy. In tuberous sclerosis, okay, many clinical features, okay, appear in the body. So let me write some of the important things here. There is intractable seizure. Okay, there is intractable seizure, means these seizures are very difficult to control, or it is one of the important cause of epilepsy. Another important points are there are some skin lesion. Okay, some skin lesions or skin manifestation. That's why it is also known as phacomatosis. One of the type of phacomatosis is tuberous sclerosis. Now, what are those skin lesions in case of tuberous sclerosis? That is known as adenoma, okay, adenoma sebaceum, adenoma sebaceum, and ash leaf spots. These are two important findings in case of tuberous sclerosis on the skin. Sometimes other solid organs are also having some tumor, okay, like conditions which are called tuber. One of the important organ is kidney, and another, if you remember, in heart also there is a finding in case of tuberous sclerosis. Can anybody tell me what is that finding in heart? Yes.
Myxoma tumor. Myxoma.
Yes.
Myxoma.
Now, actually, it is not myxoma. It is called rhabdomyoma. Very good. Rhabdomyoma. Okay. Myxoma is another type of tumor. So it is rhabdomyoma. See that. So these are some of the important points. Let's move further. Let me accept the students first. Okay. Now, another is neurofibromatosis. Now, neurofibromatosis is also autosomal dominant disorder which may run in the family. It also has a lot of different findings all over the body. Inside the central nervous system, okay, it causes epilepsy or seizure. It is also a very difficult type of seizure to control. Another important finding of neurofibromatosis, now let me share a bit of points with you. See here, we're talking about neurofibromatosis here. Okay, so there is multiple neurofibroma in the body. These neurofibroma are tumors which are present in the body. Now these neurofibroma sometimes can be plexiform neurofibroma. That means they are hanging like a skin fold. Okay, these are a bit rare. More common are solid or nodular type of neurofibroma. This is one of the hallmark of neurofibromatosis type 1, also known as von Recklinghausen disease. Von Recklinghausen disease. This is an important question which may be asked in the exam. Apart from this finding, it has one very, very important finding on the skin. Can anybody tell me what is that finding on the skin in neurofibromatosis?
Coffee outlet appear.
Coffee outlet spot.
Coffee outlet spot.
Very good. Cafe outlet spots. Absolutely. Cafe outlet spot means coffee colored, coffee colored macular lesion on the skin, or coffee colored pigmentation on the skin. Never forget this. If you know this much, a lot of points are already handled there. Out of this, bone or skeleton is also affected. Vision may be affected in case of neurofibromatosis type 1, and in type 2, one very important point is there. Acoustic neuroma occurs in type 2 neurofibromatosis, which you will study in ENT later on. Now, the third important genetic condition which is listed here is von Hippel-Lindau disease or von Hippel-Lindau syndrome. This is a bit rare in comparison to the other two, and in this condition there would be a lot of cyst formation inside the body in different organ, and this cyst, if this cyst occur inside the brain, they may lead to epilepsy or seizure disorder. And this is a type of precancerous condition. Sometimes this benign tumor, okay, may convert into a malignant tumor. And one of the important example you should never forget is renal cell carcinoma, RCC. Renal cell carcinoma can be caused by von Hippel-Lindau disease. Now let's move on. Infantile hemiplegia is one of the conditions which may be caused by these disorders, and all of these can result in partial seizure. See here, under the dysembryonic, or there is some dearrangement during the development of the brain, like cortical dysgenesis and Sturge-Weber syndrome. Cortical dysgenesis means brain is not properly developed, quite easy to understand, and Sturge-Weber syndrome, you need to know a bit about it. So let me give you some important points about Sturge-Weber syndrome now. Now, Sturge-Weber syndrome is also a type of phacomatosis. Now, phacomatosis means it has some skin finding, and along with that, it can cause central nervous system problem. Now, what type of phacoma it has? It is known as port wine stain. Port wine stain, and this port wine stain is very commonly found on the face. On the face, okay, near the forehead area, on the scalp, or around the eye. Port wine stain, never forget it. Whenever this term is asked, you can immediately think about Sturge-Weber syndrome. Apart from that, this particular person has, okay, hemangioma of ipsilateral brain. Hemangioma of ipsilateral brain. Now, this hemangioma, okay, hemangioma is a benign tumor which develops from the blood vessel, especially capillaries in this case. So, hemangioma of ipsilateral brain occurs, and this hemangioma can calcify. So, there is calcification of the ipsilateral brain. Now, remember, if ipsilateral brain is affected, then seizure occurs on which part of the body? Yes?
Contralateral side. Contralateral side of the body.
Very good.
Opposite side.
Excellent. Excellent. Contralateral or opposite half of the body. So, one important point you need never forget in case of Sturge-Weber syndrome, you see port wine stain on one side of the face, okay, but seizure occurs exactly on the opposite half of the body. This is the mechanism, because the hemangioma occurs on the ipsilateral brain where the port wine stain occurs. And third important point is intractable seizure. Okay, so these are the important point in Sturge-Weber syndrome. Now, another condition is cerebrovascular disease. You have already studied in detail in adult, like intracerebral hemorrhage, cerebral infarction, AV malformation, and cavernous hemangioma. Cavernous means vein. If hemangioma is developing from the vein or any other type of blood vessel, then also it can result in partial seizure, which comes under infantile hemiplegia classification. Let's move on. Another one is tumors, okay, the cerebral tumors. Now, the cerebral tumors can be primary or secondary. Primary means the brain, the tumor develops itself inside the brain, and secondary means it has gone to the brain from some other sources. So always, okay, so we always classify tumors like that, primary or secondary. Now, if they ask some of the example, you can quickly give. Among the primary brain tumor, you can say astrocytoma, oligodendroglioma, okay, medulloblastoma, okay, and ependymoma as the tumor. Astrocytoma, oligodendroglioma, medulloblastoma, ependymoma, and one of the most malignant type of astrocytoma is known as glioblastoma multiforme. Glioblastoma multiforme. So let me write that term for you, because many of the students want to know about that. Okay, glioblastoma multiforme. This is a very malignant type of brain tumor. This belongs to astrocytoma. Other names are quite easy for you to remember. Now, trauma is one of the important cause of partial seizure because it leads to hematoma in one of the area of the brain. Some of the infective causes can be brain abscess. Okay, bacteria are very common causes of brain abscess. Toxoplasma, cysticercosis. Now, remember, you have already studied the cysticercosis in the last semester. This is caused by which organism? Which
Tapeworm.
Tapeworm. Tapeworm.
Very good, very good. What is the scientific name of that tapeworm?
Teniasolium.
Teniasolium.
Excellent. This is Tinea solium. Tinea solium. Very good. Tuberculoma is a nodular lesion. It's a type of mass-like lesion inside the brain, which is seen in central nervous system tuberculosis. Subdural empyema is a collection of pus in the subdural space. Encephalitis is the inflammation of the brain parenchyma, which is caused by so many different viruses, and even HIV can lead to partial seizure. And some other causes would be inflammatory, like neurosarcoidosis, one of the disease. Okay, this is a type of sarcoidosis which involves the central nervous system. And vasculitis, this is a part of connective tissue disorder. So if the question is asked to you, you can always answer few of the causes like this. Okay, so let's move on. Now, after talking about this, let's talk about the investigation. What investigations are ordered in a suspected case of epilepsy? Okay. What are you going to do? What investigation you are thinking? Okay, how to proceed further? Let's talk about it. First of all, you should make sure what type of epilepsy is this. What type? Is it generalized? Is it partial? Or is it unclassified? And that is known by listening to the history. That is very important one. Never ignore the history. And probably many of the time the person is unconscious when the person was brought to the hospital. So we should take history from the observer. Okay, that observer should accompany the patient, and we should ask what type of seizure was there at home or wherever it occurs. The whole body shaking or tight, something like that, or only a part. So that is a very important information. Another one, okay, by EEG. Okay, EEG, electroencephalogram, will also give us a lot of idea about a type of seizure or epilepsy. And third important point, even if you do not strongly believe whatever the observer or informant is providing, you can admit the patient inside the ward and then observe it with the help of CCTV camera. This is known as video telemetry. So if a seizure or epilepsy comes there, we exactly know what type of seizure is it. Okay, this is one of the way. Now the type of epilepsy is also known by EEG, we already talked about. CT and MRI are important types of investigation which will tell us about the etiology or cause of seizure. If it is because of metabolic disorder, then we need to order this type of test like blood urea and serum electrolyte. Probably kidney are abnormal, and as a result of abnormal kidney function, the seizure may be there. Now, can you tell me what is the relation between kidney function and seizure? What is the mechanism why seizure comes in kidney function disorder?
So
Sir,
one happens
sir,
due to
because of the
electrolyte imbalance.
uremic encephalopathy, sir. Because of uremic
Uremic
encephalopathy, seizure will occur, sir.
Okay, and any other?
There is
Electrical
also formation of the albumin protein, and the clotting factor will decrease. So
Okay.
serum bilirubin will increase.
Okay, good. I think Taiva is also speaking. Yes, go on please.
इलेक्ट्रोलाइट इम्बैलेंस की वजह से सर.
Okay, fine. Now, okay, all of you listen. Very good answer. I've already got. Excellent. Okay, one is called uremic encephalopathy. Those toxins cannot be excreted out of the kidney. Okay, they are raised in the blood and they can cross the blood-brain barrier and can damage our brain. That is called uremic encephalopathy. Very good. Second, electrolyte imbalance. Completely agree with you. The important electrolyte in this case is sodium, not potassium. Okay, it is sodium. Now, if sodium is imbalanced there in our body, it can result in seizure. Now, another important point here is in case of renal failure, there is problem with platelet function. I agree with Saddam also. As a result of this, there may be chance of clot formation inside the brain. So this is the way you have to think in medicine. Okay, always try to correlate the thing, and you will get the answer. Liver function test is very important because hepatic encephalopathy can result in seizure, and in case of chronic liver disease or cirrhosis of the liver, there is chance of coagulopathy. There is chance of bleeding inside the brain as well. That also you can give as the reason. Blood glucose, will never forget this because hypoglycemia is one of the very important cause of seizure. We always do this in the beginning. And remember one thing, if seizure has come because of hypoglycemia, it cannot be controlled with anti-epileptic drug. You need to give glucose. And after giving glucose, the seizure will stop. And treatment is very easy. Just give glucose in the patient with the help of IV route. Serum calcium and magnesium are also done. Okay, hypocalcemia and hypomagnesemia both can result in seizure disorder. Now, another is it because of inflammatory or infective disorder? To rule that out or to confirm it, you need to do certain this type of test like complete blood count, CBC, ESR, and C-reactive protein. ESR and CRP are known as acute phase reactant. They will be high in case of inflammation and infection. Okay, so these are indirect marker. Chest X-ray to rule out whether there is pulmonary diseases. Serology should be done for syphilis, HIV, or collagen vascular disorder. Okay, syphilis, we can go for VDRL or RPR test. For HIV, okay, tell me what is a confirmatory test for HIV?
Southern blot and western blot.
Western blot. Western blot.
Where?
Western blot.
Very good, very good. All of the students are answering absolutely correctly. It's Western blot, okay? Western blot test is a confirmatory test, and the first screening type of test would be ELISA. So you can say both ELISA as well as Western blot test. Wonderful. And regarding the collagen disease, so many different types are there. So it depends. If they ask SLE, you can say ANA and anti-double stranded DNA as the answer. And CSF, don't forget, if you think this may be an infection like meningitis, meningoencephalitis, brain abscess, cerebral malaria, go for CSF analysis by doing lumbar puncture. But one point is so important here: before you do CSF analysis or lumbar puncture, make sure the intracranial pressure is not very high. Otherwise, there is a chance of cerebral herniation when you do lumbar puncture. So these are some of the important tests. Let's move on. Another important question which you may get is, what are the indications for brain imaging in case of epilepsy? Do all the patients need brain imaging in epilepsy or not? That's the question. Now, brain imaging means CT scan or MRI. Now, look at the indications here. If epilepsy starts after the age of 20, okay, we definitely need. Seizures, if they are focal, okay, focal seizures are usually associated with space occupying lesion inside the brain, okay, so we need to diagnose them. EEG shows a focal seizure source, and if control of seizure is difficult, or if the condition of the patient is deteriorating even after taking medicine, then you have to go for brain imaging. These are the theoretical point. Now let's come to the practical point. What is happening these days all over the world? Whenever a patient, okay, comes to the hospital or clinic with seizure disorder or any suspected case of epilepsy, you want to go for brain imaging. Sometimes the doctor wants to rule out some dreadful differential diagnosis. Sometimes there is a lot of pressure coming from the patient party side, so we cannot avoid that situation. Just to make them quiet, we need to order brain imaging. So this is the practical thing I'm sharing with you. Now, what are the differential diagnosis of seizure? Sometimes, okay, some other condition may mimic seizure, and we wrongly diagnose this case as a seizure disorder. Now, what are those? One of the important condition is syncope. Now, what is syncope? I want to hear some answer here. Yes?
Temporary loss
Decreased
of
blood flow
consciousness.
to
Temporary loss of consciousness.
cerebral perfusion.
Sudden fall down of a person due to decreased diffusion to the brain,
Okay. Now see there.
mainly because
Good. So I can hear most of the answers. Very good. Students are answering quite confidently. Syncope is a result of heart disease or result of cardiovascular system disorder. Never forget to add that point, okay? Very good. It is a transient loss of consciousness. Only for a short duration there is loss of consciousness, and this occurs because of decreased blood flow towards the brain. So if you add these three things together, the meaning is complete. So it's a type of cardiovascular system disorder where there is decreased blood flow towards the brain, probably because of decreased cardiac output, and there is a transient loss of consciousness. So this is syncope. Now, why it is a differential diagnosis of seizure? Sometimes what happens, even after seizure, like a complex partial seizure or generalized tonic-clonic seizure, the person will lose consciousness. Okay, and if syncope is a prolonged type of condition, if it is not recovered in time, then because of ischemic effect to the brain, the person will have seizure later on. I'm sure you are getting what I'm saying here. If there is prolonged loss of blood flow to the brain, seizure can happen, okay, and the seizure can also leads to loss of consciousness. So many of the time we confuse between these two. That's why it is considered as a differential diagnosis. Psychogenic seizure. Now this is a psychiatric manifestation. Many of the time, it is also known as a pseudo seizure. Okay, pseudo seizure. So let me write that term for you. Pseudo seizure means it's a false seizure. It looks like seizure, but actually it is not. And many of the time, the patient, okay, is having conversion disorder. Okay, it's a type of a psychiatric disorder. Metabolic conditions, okay, can be a differential diagnosis of seizure disorder. One of the important example I can take here is hypoglycemia, hyponatremia or hypernatremia, renal failure, and hepatic failure. All of these can be listed under metabolic disorders. Vertebrobasilar insufficiency means the vertebral arteries and the basilar artery are having some problem, so that there is decreased blood flow, okay, into the brain. Now, one of the important manifestation of this is called drop attack. Drop attack, because of the problem in the balance, and it almost looks like, okay, seizure sometimes, because the patient is falling. And in seizure disorder also the patient falls, especially in generalized tonic-clonic seizure. There is a sudden bang or the fall on the ground. That's why it can be confused. Sleep disorder, many of the children or even the adult, they shake their body during sleep, or sometimes they scream also during sleep. Can be confused sometime. And movement disorder, there are so many different types of movement disorder like chorea, athetosis, hemibalismus, okay, tics. All of these are example. And if we do not take history properly, we may confuse this with seizure. Now, if somebody asks you how to differentiate them, you can always take the help of history taking, physical examination, and investigation. Now, with this, let me enter into the very important part of this topic, that is treatment of seizure disorder. So every student should know this quite well. Now, see here. So first of all, we should know some principles how to treat a case of seizure disorder. The first one is treatment of underlying conditions. Okay. If this seizure is because of meningitis, let's go and treat meningitis. Then seizure will be controlled on its own. Encephalitis, go for the treatment. Brain abscess, go for the treatment. Cerebral tumor, go for the treatment. Neurocysticercosis, go for the treatment. So this is the meaning. Second is avoidance of precipitating factors. Now, those precipitating factors I mentioned in the beginning of this class, or even in the last class which we discussed, there we talk about this. Lack of sleep, extreme tiredness, watching television or using laptop or using mobile phone for a long time, all of these can be precipitating factors. Okay, so the person should be careful. Anti-epileptic drug therapy is one of the very important step. Okay, but many of the student or the doctor think drug therapy is the only way to treat these conditions, but the answer is not that only. See there, if we do not avoid the precipitating factor, or we do not treat the underlying condition, then seizure disorder cannot be controlled completely. Now, what are these underlying conditions? Though I have already take the name of those during the discussion, but still we can revise them in this slide. If there is hypoglycemia, correct it. If there is dyselectrolytemia, correct it. Now, regarding the electrolyte, sodium, okay, is the important one, then potassium. Potassium imbalance doesn't lead to seizure, but sodium imbalance definitely leads to seizure. Both hyponatremia and hypernatremia can lead to seizure, and hypoglycemia I already talked about. Drug overdose can also result in seizure. There's so many different drugs name you can take. Any drug which can enter into the brain can result in seizure disorder, okay, like a tricyclic antidepressant and all those things. Even lidocaine, important type of local anesthetic, if we you know, inject that lidocaine into the blood vessel, it can result in seizure. Another one, brain tumor, vascular malformation, or cerebral abscess. So you have to treat these underlying condition if they are present. Let's move on. Now another one is avoidance of precipitating factor. Now see there, avoid sleep deprivation. A person who is having seizure disorder or epilepsy should have at least 8 hours sleep in a day. Means in 24 hours, 8 hours sleep must be there. This is such an important point. Avoid or limit alcohol intake. Absolutely, there is no need of any explanation here. Alcohol will decrease the seizure threshold so that seizure can come easily after taking alcohol. So it is not for the epileptic patient. In rare cases, avoid flickering light. Okay? Flickering light, like in a discotheque, there's a lot of flickering light, isn't it? That is the type of example I'm giving. And similar type of flickering light can also be there from the television. So do not watch television for a long time. We are not saying do not watch it at all. You can enjoy, but not for a longer time. Do not continuously keep on watching the mobile phone or using it. Okay, these are also not good for the epileptic patient. And long-term music listening is also not good. Stress should be reduced. Okay, these are some of the important points. Now, what are the general instructions we give to the patient of epilepsy or seizure disorder? This is important point, and a doctor should tell these things to the patient. Okay, don't only focus on the medicine. You need to exactly explain these things to the patient party, both for the patient and for the family, or in the friend circle who is accompanying the patient in the hospital. Now see here, work or recreation above the ground level with dangerous machinery or near open fires or water should be avoided, because anytime the seizure may come, and if it is a generalized type of seizure, there is high chance of loss of consciousness and the person may fall into this dangerous area. Okay, and there would be serious injury or even death. So this is a very, very important point. Second one, should take only a shallow bath and should not lock the bathroom door from inside. If the patient, I should say, was taking shower and the bathroom door was locked, and during taking shower, if the generalized tonic-clonic seizure comes there, he may bang the head on the bathroom and he may be unconscious for a long time after that, and nobody even knew because people think he is still taking shower. So these things are very, very important. Patients should not lock the bathroom door, or there should not be any lock in the bathroom which is used by epileptic patient. Cycling should be discouraged until at least 6 months freedom from seizure has been achieved. Now, cycling is a good exercise, we all know that, but why we are discouraging it here? Because of the same fear. The person may get epileptic attack while cycling and he may fall and had a serious type of injury. So only after 6 months of freedom from seizure he can go for cycling. Similarly, swimming, fishing, or boating should always be in the company of someone. Mountaineering should be discouraged. The reason is still the same. There is a grave danger to the life of the epileptic patient when they go for this type of activity. So now let's talk a bit of practical things here. In our dorm, in the university also, few of the students are having epilepsy or seizure disorder. So whenever they go outside for this type of activity, some friends who are a responsible friend, that word I want to use here, responsible friend should be there to accompany, so that if they fall in trouble, they may be revived. Now, what you do, okay, if a seizure comes in front of you, or if seizure comes at home, when we do not have any medical equipments or any drugs, what should we do during that time? Okay, let's talk about it. So this is called first aid, which is done by relative and witnesses. Though we are a doctor, you know, we may not have a lot of drugs or a lot of instruments at home, so we may also fall under this category. So see there, okay, move person away from danger. We need to do that very quickly, like fire, water, machinery, or furniture. After convulsion cease, turn the patient into recovery position. This is called semi-prone position, so that there is no chance of aspiration. Do not put the patient into supine position. There is high chance of aspiration as well as blocking of the airway by falling the tongue backwards. Ensure airway is clear and do not insert anything in mouth. And if convulsion continue for more than 5 minutes, okay, call for urgent medical attention or transfer the. So I was talking about the first aid that is usually done by the relatives and the witness. Witnesses means the people who watch a seizure. Okay, so what should they do if it occurs in the home or in the office or in the shopping mall or wherever outside the hospital setting? Now, that's what we are talking right now. So one of the important point with the students, are confused is what is this recovery position? So let me explain this once again. See here, recovery position means we keep the patient in lateral position, usually left lateral position, and don't put the patient in supine position. There are certain advantages of this left lateral position. Number one, the tongue doesn't fall back and block the airway in lateral position. It will fall on the side, so there is no chance of blocking the airway of his or her one. Second point, if there is some vomitus which is present in the oral cavity, it can trickle down from the corner of the mouth in case of lateral position. But if the person is in supine position, it will directly go into the airway. That's why in a comatose case, okay, in a comatose case, always put the patient into recovery position. That is the important point. And ensure airway is clear. If there is some vomitus, remove it. Okay. Then slight extension of the head should be done. Then another important point, if the person is drowsy and confused for some 30 to 60 minutes, we should not leave the person alone until fully recovered. And if the seizure is continued to coming for more than 5 minutes, transfer the patient quickly to the hospital. These are the different things we have to consider. Let's move on. Now, the person reaches hospital or was brought to the hospital. What should you do as a doctor? These are the immediate medical attention we provide. Ensure airway is patent. Airway management is always the first thing, because if there is hypoxia because of obstruction of the airway, patient may die in a short time. So airway should be patent. Now, what are the different way to keep this airway patent? So maybe students do not know about this knowledge, so let me share with you. Number one is the positioning of the patient again. Then the position is usually the lateral position. First. Second is slightly extend the neck or head, a slight extension, and that is done by putting a pillow, okay, or a fold of the towel, okay, beneath the shoulder. So if we do that, okay, it will be slightly extended, the neck or the head, I mean, and the airway will be straight. There's no chance of blocking the airway if we do this. The third, if the person is in coma, then the airway is not protected even by this mechanism. So endotracheal intubation is the best. And that endotracheal intubation should be a cuff type of tube. So these are the important way to secure the airway. We'll talk like this in many other subsequent classes also. Give oxygen because this patient is unconscious. Okay, oxygen should be given because there is a chance of cerebral hypoxia. Give intravenous anticonvulsant to stop that ongoing seizure, and the best is benzodiazepine, and among that diazepam or lorazepam. So give diazepam 10 milligram if the person is adult, and if the person is a child, okay, we need to calculate according to the body weight. Okay, usually 2.5 to 5 milligram would be fine, but the best answer would be calculate according to the body weight. If the seizures are not controlled, even after giving one dose of diazepam, you can repeat it again. Okay, you can repeat it. So this is the point. Consider using long-acting anti-epileptic drug if the seizures are ongoing. Consider taking blood for anticonvulsant level if non-epileptic patient. Now, what do you mean by this? Many of the epileptic patients, they develop repeated seizure. So this may be a one episode of that type of seizure, you know. So he may be already taking some anti-epileptic drug like phenytoin, carbamazepine, valproate, something like that. So it is always better to take blood for anticonvulsant level analysis. And if the dose is less, okay, or the level of anticonvulsant is less in the blood, we can always increase the dose to maintain the level. Investigate the cause. We always do that. And the important investigation, if you remember, we discussed before the break. There may be neuroimaging, there may be serum electrolyte, there may be CBC, there may be blood sugar level. Okay, so these are the important points. Now, another important question here, okay, which anti-epileptic drug should we use and when? Okay, when should we use the anti-epileptic drug? What are the indications? See here. If there are 2 or more episodes of seizure of unknown etiology or a known cause that cannot be reversed, then you go for anti-epileptic drug. 2 or more episodes of seizure of unknown etiology, this is epilepsy. So in epilepsy, you're definitely going to use anti-epileptic drug, no doubt, or a known cause that cannot be reversed. For example, the repeated seizure which are coming after the meningitis, and meningitis has caused some damage inside the brain. So we need to use anti-epileptic drug to control it. Another point is single seizure due to an identified lesion like CNS tumor, infection, trauma should be treated. Even single seizure, okay, with these identified lesion, anti-epileptic drug should be given. Usually, what is the common consensus? If there is a single generalized type of seizure without any identifiable cause, you wait, okay, you wait for the time being. You don't immediately give anti-epileptic drug. But if there is a single episode of partial seizure, it is highly associated with some space occupying lesion inside the brain. So we definitely start anti-epileptic drug even with first episode of seizure. So what I'm saying here, if generalized seizure is there and this is the first episode without any identifiable cause, you can wait for the another episodes of seizure to start anti-epileptic drug. Single seizure associated with one or more of the following, we should use anti-epileptic drug. Now let's analyze them. Abnormal neurological examination, definitely don't take any chance because there is already serious damage to the brain. That's why the neurological exam is abnormal. Second, seizure presenting as a status epilepticus. Seizure presenting as status epilepticus, we need to go for the anti-epileptic drug because status epilepticus is a serious condition where the ongoing seizure is more than 30 minutes. Post-ictal or TORS paralysis, anti-epileptic drug should be started. Now, what is TORS paralysis?
TORS paralysis is occur when in case of transient ischemic attack, the The unconscious state is between from 24 hour to 48 hour. So after that, when a person is coming to conscious, it feels very weak and exhausted.
Okay, good, good, good. Now, listen here once again. Todd's paralysis, okay, is a transient type of weakness or paralysis of the limb and body after generalized type of seizure. So he is absolutely right. This can be considered as one of the differential diagnosis of TIA, a transient ischemic attack, because it will recover within 24 hours. That is Todd's paralysis. So Todd's paralysis occurs after generalized type of seizure. If there is a strong family history along with seizure disorder, we use anti-epileptic drug because there is a chance of recurrence. And abnormal EEG with epileptic attack, we always start anti-epileptic drug. So these are some of the important points. Now another big question, which are those anti-epileptic drug, also known as anticonvulsant? So before we go into the slide, let me quickly mention the classification here. These are roughly divided into two broad group. One is called conventional or first class anti-epileptic drug, and second class or newer type of anti-epileptic drug. Now the conventional or first class anti-epileptic drug is still used very commonly all over the world, like phenobarbital, phenytoin, carbamazepine, and sodium valproate, very commonly used. Even benzodiazepines comes under that list. And second, they are relatively newer drug like gabapentin, lamotrigine. Okay, then any other name you remember? I want to hear few more there. Yes.
Topiramide,
Topiramate,
topiramide, levetiracetam,
Very good.
topiramate,
Topiramate, levetiracetam, very good. Okay, primidone, okay, primidone. These are all different types of anti-epileptic drug which are called as newer generation
Epivol.
or second line drug. Very good. Okay, now some students are causing noise, so let me mute. Okay, now see here, phenytoin is one of the very commonly used drug, and from the exam point of view, very commonly asked as well. This phenytoin acts like a membrane stabilizing agent. Okay, this is the mechanism of action of phenytoin, and this blocks the entry of sodium as well as calcium inside the CNS neuron. This is the dose of phenytoin, 3 to 6 milligram per kg per day. But remember one important point: phenytoin should be started as a loading dose. Loading dose is given as a 15 to 20 milligram per kg. Then this is a maintenance dose. The adverse effect of phenytoin, if it is used for a longer duration, are very important from the exam point of view, like hypertrophy of the gum, hypertrophy or hyperplasia of the gum. So let me underline this. These are repeatedly asked in the exam. Another is hirsutism, abnormal hair growth in unwanted parts of the body, glucose intolerance, there may be hyperglycemia, megaloblastic anemia. Okay, megaloblastic anemia. We all know megaloblastic anemia occurs because of lack of folic acid and vitamin B12 deficiency. Lymphadenopathy, okay, nausea and vomiting, ataxia, and nystagmus. These all are different adverse effects of phenytoin, and there are certain other causes of hyperplasia or gum hypertrophy also. One of the disease is known as scurvy. Remember, scurvy, vitamin C deficiency. Another is leukemia, especially AML, can also result in hypertrophy or hyperplasia of the gum. Very commonly asked question in the exam. Phenytoin can cause fetal hydantoin syndrome if a pregnant lady takes it. So it is a teratogenic drug. It is called as fetal hydantoin syndrome. There's a lot of congenital malformation which occurs in this condition. Phenytoin, okay, this is important drug. Now, let me ask you a simple question here. Okay, so let me unmute you first. Yes. Now, if my patient is a young girl, okay, who is a non-epileptic, should I give phenytoin to her or not?
No, sir.
No, sir.
No, sir.
Because it can cause hirsutism.
No, sir. It will cause hirsutism in female.
What is this?
Exactly.
It will cause hirsutism.
Exactly.
And also
Okay.
pregnancy.
Very good. So many of the students have nicely answered because it causes hirsutism. We should not use phenytoin in a young girl. But if a boy comes with this type of problem, you can safely prescribe phenytoin. But remember, it can lead to side effects. So you should monitor those side effects in the patient. That is the good answer. Now, another important drug, okay, another important drug which we use in the patient is carbamazepine. So this is also a membrane stabilizing agent. The dose is 15 to 35 milligram per kg per day. You don't need to remember this dose now. If it is difficult for you, when you start practicing, it will come automatically. Some important adverse effect of carbamazepine are drug reaction, very, very important one. There are different types of drug reaction which we discuss in our dermatology classes. One of the important condition is known as Stevens-Johnson syndrome. Stevens-Johnson syndrome, very severe type of drug reaction or allergy. Another is known as toxic epidermal necrolysis, TEN, the most severe type of drug allergy. Carbamazepine can be associated with both of those conditions. Ataxia, dizziness, diplopia, vertigo, aplastic anemia, leukopenia, and hepatotoxicity are some other side effects. But overall, carbamazepine is considered a safe drug, and it is a hugely popular drug in the treatment of partial seizure. And it is also considered relatively safe in pregnancy. Phenobarbital is another member of the first generation anti-epileptic drug. Okay, not very commonly used these days, but one important point I like to highlight: phenobarbital is considered still the drug of choice in the control of neonatal seizure. Neonatal seizure, we still love to use phenobarbital for the control. Valproic acid is known as broad spectrum anti-epileptic drug. Okay. So let me write that come for you here, broad spectrum. Now why it is called broad spectrum anti-epileptic? There is a reason, because it controls both generalized as well as partial seizure. So broad spectrum anti-epileptics, valproic acid. It acts as an agent which potentiates the effect of GABA. Now, what is GABA? Yes?
Inhibits a neurotransmitter. Inhibits a neurotransmitter.
Gamma aminobutyric acid inhibit a neurotransmitter.
Very good. So I already got the answer from many of the students. Excellent. The full name is gamma aminobutyric acid. Gamma aminobutyric acid, and it is an inhibitory type of neurotransmitter. So if this valproic acid potentiate the effect of inhibitory neurotransmitter, it will block those firing neurons, and that's how seizure would be controlled. So dose is 20 to 60 milligram per kg. Adverse effect, some of the important adverse effect which is asked in the exam, again ataxia, sedation, hepatotoxicity, and alopecia, as well as weight gain. Let me write that weight gain here. Weight gain is an important side effect of valproic acid. Alopecia, weight gain, hepatotoxicity, and ataxia. These are the important ones. This is very commonly used these days in the control of different type of seizure because it is a broad spectrum anti-epileptic drug. Now, let's move on. Some other are ethosuximide. This is a drug of choice in case of absent seizure. Ethosuximide. Absent seizure. The seizure is for a very brief duration, okay, and patient will not fall. Patient will maintain the posture. The drug of choice, ethosuximide, or some other doctor, they want or they can use valproic acid as well. Okay, and benzodiazepines, no need of any discussion. Many students know it already. Gabapentin and lamotrigine, these are the newer generation drug. Okay, the detail you can see on your own. Just remember few other name because these are the favorite questions in the exam. Now let's talk about the important practical information here, which are the chosen or first line anti-epileptic drug for the particular type of epilepsy or seizure. Now this is the important question. See here, if the seizure is partial or secondarily generalized, which is known as secondary generalized tonic-clonic seizure. Remember, it starts as a partial and later on becomes secondarily generalized. That's why it's still a part of partial epilepsy or seizure. So the first line drug is carbamazepine, second line drugs and third line drugs are so many. So let's go through the name. Lamotrigine, okay, sodium valproate, topiramate, tiagabine, and gabapentin. In third line, clobazam, okay, this is a type of benzodiazepine, phenytoin, primidone, phenobarbital, okay, oxcarbazepine, levetiracetam. This is a very popular newer generation drug these days. It's a very effective as well. Vigabatrin and even acetazolamide. Acetazolamide is not anti-epileptic drug though. It belongs to diuretic family. Primary generalized tonic-clonic seizure, like a grand mal seizure, this is another name. These days, the first line drug is sodium valproate, but there are so many second and third line drug. Absent seizure, ethosuximide. Second line is sodium valproate. Myoclonic seizure, sodium valproate is the first line and clonazepam is the second one. Okay, so try to remember this because it is very, very useful when you start practicing. Now, though we already talked about this, let's repeat again. What are the guidelines for anticonvulsant therapy? These guidelines will really help us in the management of the patient. You start with one first line drug which you have just seen. Okay, you start with one first line drug in the beginning after you have decided to use the medicine. You start with low dose first, gradually increase the dose, okay, until the seizure is controlled or until side effects arises. This is the way. You start with low dose, okay, gradually increases until the seizure is controlled or side effects arises. And during this time, the drug level really help us. Okay, if the drug level are still low and if seizure is not controlled, I can increase the dose and I can reach to that level which is considered the highest level. Now let's move on. Check the compliance from the patient. Now compliance from the patient. Now what do we mean by that compliance from the patient? Compliance means how well the patient is taking the medicine. Is the patient following our order or not? Okay, and to have this better compliance, give the anti-epileptic drug which has minimum doses. For example, once a day or twice a day. Do not give that type of drug which is used 3 to 4 times a day. It will decrease the compliance level in the patient. Another important guideline is if first drug fails and if seizure continue or already the side effects came, then start the second line drug, okay, whilst gradually withdrawing the first. This is such an important point. For example, if you have used carbamazepine as the first line drug, okay, but carbamazepine you have already increased to the maximum dose, but the seizure is not controlled. So what should you do now? You start the second line drug like sodium valproate and gradually decrease the dose of carbamazepine and then only stop. If you suddenly withdraw carbamazepine, there may be withdrawal type of seizure. and it may result as status epilepticus. This is a bit similar to steroid use. Corticosteroids are also never stopped suddenly after a prolonged use. Same type of situation. Try 3 agents singly before using combination and beware of drug interaction between them. Now, what do you mean by that? For example, I've already started carbamazepine. Carbamazepine fails to control the seizure. So I have started sodium valproate and withdraw carbamazepine gradually. Now sodium valproate is my second drug. Still, if that sodium valproate is not controlling the seizure, maybe I want to use some newer generation like gabapentin or lamotrigine or levetiracetam, something like that. So if that also fail, then only you combine the drug together. This is important guideline. Do not use more than 2 drugs in combination at any time. And then if above fails, consider whether occult structural or metabolic lesion is present and whether seizures are truly epileptic or not. This is called failure of medical therapy. So you need to think about some surgical treatment now, and to do the surgical treatment there has to be real pathology in the brain. We do not go for any surgery just like that, we need to diagnose it first and then only go for it. Or you think about, is it a real seizure or is it a case of pseudo seizure? If there is no control even after using all these medicines, then think again, revise your diagnosis. So all these things are very, very important for the management. Now another important part of the therapy or treatment is monitoring. One is effective control of the seizure, and second is whether the drug is causing toxicity or not, so that we can avoid it. So monitoring is really necessary. We call the patient after starting the drug, maybe after 2 weeks, and then examine the patient fully. Now another important question, okay, is when to discontinue the treatment. When, isn't it? After how long we should discontinue the treatment or the therapy? Now see here, this is a big decision because so many patients, they develop some side effects to the drug, and so many of them, they don't want to use the drug for a long duration, isn't it? They want to discontinue it as soon as possible. So what should we do? Approximately 70% of the children and 60% of the adult who achieve seizure control can discontinue the therapy. This is a very good data. See there, almost 70% of the children and 60% of the adult who have a good seizure control can discontinue the therapy. So we have to give this counseling to the patient party. They don't need to take the drug for lifelong. Another point is the recurrence rate of seizure after drug withdrawal is about 40%. So the seizure can come back again, and the type of treatment is again the same one. Withdrawal of drugs should be tried in those who fulfill all the following criteria. So I want you to pay attention here. These are the very important practical information. If there is complete seizure control for 2 years after you have started it, then you can safely discontinue the therapy. Now what does that mean? Let me highlight here. That means today I have started the drug in the patient. Now we count the days, and till 2 years, if no seizures will come, then we can stop the therapy after that time. Okay, so this is important one. Another point, if there is a single seizure type, we can stop the drug after 2 years. If there is normal neurological examination, then we can stop, and after confirming that the EEG has turned to the normal thing, then we can discontinue the treatment. So these are all very, very important points, because patient wants to know. They'll definitely ask you, doctor, till when I need to take the drug? So this is the important point. The most important out of them is if there is no seizure for another 2 years. How to withdraw anti-epileptic drug now? Okay, what should we, what are we worried about this withdrawal effect of anti-epileptic drug? The drug should be gradually tapered, okay, over 6 to 12 months. There's a long duration, 6 to 12 months, and never stop abruptly. Otherwise, you will induce withdrawal seizure, and that withdrawal seizure usually manifests as status epilepticus, very difficult to control. I've already explained this. We can compare this phenomena with the steroid withdrawal effect. Now, sometimes epilepsy or seizure disorder can relapse, and these are the predictor of relapse. Relapse means it is coming again in the future. If the person is under the age of 16 years, there are high chance of relapse. If it is tonic-clonic seizure, it has chance of relapse. Myoclonic seizure is difficult to control as well as high chance of relapse. Treatment with more than one anti-epileptic drug, AED, okay, means the seizure is already difficult one. This epilepsy is an intractable type probably. Seizures after starting anti-epileptic drug, not controlled well. Any EEG abnormality associated with seizure, and if there is identified structural lesion inside the brain, like a tumor, like neurocystic sarcosis, for example, there is high chance of relapse until and unless we go for the definitive treatment. So these are important points which we should explain to the patient party. Now, another important part of the management is a surgical management. So what type of surgical therapy are there for the patient? Now see here. First of all, we should select the patient, which patients are appropriate for surgical management, or for which type of patient we should go for surgical management. This is the important point. Now to answer this, okay, we should have certain indications. Now see here, epilepsy syndrome which are not responsive to medical management. So first of all type of epilepsy should be tried with the medical treatment. If it is failed, or if it is an intractable type of epilepsy, then you need to go for surgical management. And that is unacceptable seizure control despite maximum tolerated doses of 2 to 3 appropriate drug as monotherapy. We label it as a failure of medical treatment, so surgical treatment is done. Another, okay, some of the epilepsy syndrome where surgery can be done, like one area of the brain, okay, we confirm yes the seizure is coming from there, we localize that area, then surgery can be done in that particular area. Now, what are the important surgery? Now, see here, these are divided into potentially curative and palliative. Now, potentially curative means after this probably the person will be cured, there will be no more seizure, and that can be done by resecting the epileptogenic focus inside the brain. Before that, we should exactly know from where the epilepsy is coming, and there are different ways, okay, to know the localization. One is EEG, another is neuroimaging. Now another is palliative therapy. Now I want to ask this question to you, what is palliative therapy? Yes,
just increasing quality of
Decrease
life,
symptom.
Just
not treating the cause, just
increase the
Continuous
curing its
quality of the
symptom.
patient.
very good. Different students have answered in a different way, but absolutely correct. Okay, very good. Palliative means you just decrease the symptom. There is no hope of cure. So you just improve the quality of life by decreasing the seizure. This is a sort of symptomatic treatment. Now see here, we can go for partial resection of epileptogenic region so that there is a decreased chance of epilepsy, and you can go for some destructive type of surgery like a corpus callosotomy so that the seizure cannot spread from one cerebral hemisphere to the other. so that the generalized tonic-clonic type of seizure, has a very decreased chance to occur. So let's talk about the issues regarding pregnancy and lactation. That means if a pregnant lady is a epileptic patient, or if she develops seizure disorder or epileptic attack during lactational period, what should we do? What are the important drugs for the control? Most of the drugs or anti-epileptic drugs are teratogenic during pregnancy. Remember this point. The likelihood of teratogenicity increases with multi-drug combination. If I have used multiple drugs when the seizure was not properly controlled, then there is a high risk. Among them, some of the drugs are relatively safer than the other. So what are those drugs? Carbamazepine from a first generation drug is relatively considered safer. Another is a phenobarbital in comparison to other. Whereas from the second generation, lamotrigine and gabapentin are also relatively safer. These are the important information. During the lactational period, there is no contraindication, okay, for the use of anti-epileptic drug. And after the birth of the baby, if she is using oral contraceptive pill as the method of family planning, then carbamazepine, phenytoin, and phenobarbital, if they are used, any one of them are used as anti-epileptic drugs, then we all know what they are doing, okay, inside the liver. There is cytochrome P450 enzyme system inside the liver. That cytochrome P450 enzyme system is activated. Okay, now see that cytochrome P450, okay, enzyme system. This is activated by this drug. As a result of this, the oral contraceptive pill is very rapidly metabolized. So there would be no effect of oral contraceptive pill, and in other way, the lady will be in false belief that she is being protected by the oral contraceptive pill regarding pregnancy, but actually because of the fast metabolism, she is not having that effect. So we need to be very careful in this situation. Either you need to increase the dose of oral contraceptive pill, which is not usually done. Rather than that, you change the modality of contraception. You give another way of contraception or offer another way of contraception in the lady. This is a very important information. Let's move on. Okay. Now see here. What happens, okay, to that epileptic attack after 20 years of starting the therapy? Now we want to know about this, isn't it? This is about the prognosis of epilepsy. 50% of them become seizure free without drugs for last 5 years. This is a good point. 20% become seizure free for last 5 years but continue to take medication, and 30% seizures continue in spite of anti-epileptic therapy. Means they may require lifelong therapy. Okay, so epilepsy is a difficult medical condition to control. So let me stop here for the time being. The next class will be about